So I'd like to welcome you all to this webinar. So it's a practical approach to smoking cessation. I'm sure you're going to enjoy it a lot. We have two very distinguished speakers. I'm sure you all know Dr. Abdullah Shahab, Professor of Cardiovascular Medicine and Editor-in-Chief of New Emirates Medical Journal. And we also have Dr. Sandy Gupta from UK. He's a consultant cardiologist from Webb's Cross Barts NHS Trust. Just housekeeping issues initially. I would like to invite you to submit your questions as soon as you have them. Just submit them in the chat, and we're going to have at the end a half an hour discussion where both speakers can answer all your questions. So without further delay, I'd like to ask Dr. Abdullah to start on the topic of e-cigarettes, new devices, and the harm reduction debate in context of benefits of quitting. So go ahead, Dr. Abdullah.
Thank you very much, Dr. Juwaria, for chairing the session. I think I'd like to thank the Emirate Cardiac Society for running this series of events, and thanks Pfizer for making this available for our audience. When I think something very important, risk and how to manage it, and there are many ways. We're going to discuss this tonight. So as I said, I'm learning in this area. It's vaping, so spotlight on e-cigarette, new devices, and harm reduction. So I'm trying to give some highlight on this. And again, I say this is we are living a COVID time. We are living in COVID time. We have to be not allowed to do any smoking, but we'll see. So I have no conflict apart from honoraria from Pfizer and some advisory activity, but nothing with the tobacco industry or e-cigarettes. So this is the reason people are tempted. Advertisement in the past in 60s, 70s. You look younger, you look more handsome if you smoke. So many things were kind of tempting us to do that. So just briefly, all of us know people died so far of COVID, I think just above 1 million, but people dying of smoking is 7 million, maybe 9 million now. So some new data says, and cardiovascular disease even double of that. So tobacco is a true risk factor and associated with cardiovascular disease, the lung and the rest. And I think my colleague going to speak about that. So many ways to help us to quit smoking. I think the most important one is that decisions comes from a person, him or herself, to decide about that. Then comes some support. That could be mental support, could be some pharmacotherapy, some behavior therapy, and today or could be a e-cigarette, for example. So really, data shows that the most of the quit of the smoke comes from you don't need any intervention, but there are remain people who need some help, which comes from different. We have nicotine gum, nicotine patches, to the the e-cigarette, which some people claim. So why e-cigarette? You can see again lots of advertisement be about this recently. You see it everywhere, and different type. We have e-pipe, e-cigar, large size, long size. So what they contain, many things. In addition to nicotine, so you don't know really what's available in this, the content of these, from vegetables to the heavy metals to ferrins. That's why people say, that's why there's a conflict. Nobody knows is it harmful, harmless, or less, or not harmless. And so lots of. That's why the conflict, because we don't know the content of this, and there is no one kind of, it's like cigarette, what's inside, but this one we don't know. And of course, quitting smoking was the easiest thing I've ever done. Thanks to, you see something like this. Is this true? Vaping saved my life. Especially if this is associated with some star. Nowadays you see some nice stars and of course, people, especially the teenagers, like to follow the stars, like footballs and the rest. So what's inside these? Is vapor. We are vaporing that, and battery and coil and liquid, and contain many flavors, and these are where the problem is. So e-cigar around 95 less harmful. This is claimed by I think in UK, our colleague from there as well. And so it's a belief that 95% less harmful than tobacco, and some people even say 98 less harmful. And you see the opposite in other. Depends how you interpret, the data and from where this data is coming from. But yes, maybe it's less harmful than tobacco in general. But if you're going to continue smoke this and this and the cigarette, I don't think would. So what's inside? Liquid, all these. So you don't know where the harm coming from. And so nicotine, we know the nicotine, as people say, it's like caffeine. You don't get any harm, but it is associated with there's a theoretical as well as real danger from nicotine itself, as well as the oxidized chemicals which come from e-cigarettes and may result in sudden death. And we have some reports about that. Effect on the blood pressure, of course, blood pressure, as we know, stiffen the arterioles, endothelial dysfunction, and that's caused cardiovascular, and being reported actually. Those who are daily having vaping, had cardiovascular risk, and that be reported. So there is a theoretical risk and actual risk on the lung. We know some people, some expert actually reported that it's like become, the alveoli become like a balloon and they never go back to normal. And that's why it's being reported, the people who had lung and it's really severe, 500 be reported, I think 8 died and something like that. So CDC urged a clinical to report possible cases of unexplained vaping-associated pulmonary illness in their state local health department. I think all aware of that. So they called ENDS, so electronic nicotine delivery system, and there is an electronic non-nicotine delivery system. I don't know what's the point of that. And tobacco products like having smoke. So there are many types available. So this is the truth. This is the fact. The fact is, in 2011, 6 million consumers of this. And they expect 2021, 55 million. So what's happening? I think people are, taking this as like a replacement. We thought it would be a replacement of cigar, but it's not. It's really not. It's not. It's just become like they're having this with the cigar, and that's what's happening in most of the places among young people. Electronic cigar sales in the United States, you can see, it's booming. It's in UK as well, and we thought the UK is like has got the best place for quit of smoking, but was it due to the electronic cigarettes or due to something else, which we're going to discover soon? Electronic cigar use and myocardial infarction among the adults in U.S. population assessment of tobacco and health. So, the people tried, okay, instead of having cigarettes, let's give them this, but it make the situation worse. Open BMJ, electronic nicotine delivery system, and electronic non-nicotine delivery system for tobacco smoke cessation or reduction, systematic review. So this is where the problems, we don't know. That's why we do a systematic review to see where is it harmful, is it useful, what is it? So the conclusion of this one says very limited evidence regarding the impact of ENDS and on tobacco smoking cessation. So very limited. Reduction or adverse reaction. Data from the randomized control are low certainty, and observational studies of very low certainty. So it tells you, it depends what you read, but the systematic review will give you an overview. So we need more data on this field. But these are some of the association, as I mentioned, with the nicotine. Nicotine is not harmless. It is harmful in terms of cancer, cardiovascular disease, and associated with the cardiovascular diseases. So this is the evidence about electronic cigarettes. Foundation built on rock or sand. And I'm confused myself. I don't know. I mean, it's conflict of interest there sometimes. People who are supporting this means they have some association. Lack of hard evidence, uncertainty around harms. Some people show the harm in a light and in a beautiful way, and some of them show it in a really harmful, serious way. Uptake of e-cigarette among young non-smokers and underestimated, of course, is actually increasing. And at least in places I've been to, I've seen a lot among the young population. Scarce evidence about the risk of bystanders is not synonymous of lack of effect. Lack of evidence of risk from long term, we don't know. Of course, this is it's been there for last this 10 years so or 15 years. So we need to wait and to see the long term effect. So this is what I think the status now. What about the any? Does it help us? Does it help the smokers to stop smoking? So we can say, look, we have medication, we have behavior therapy, we have e-cigarette. Does it help? So nicotine electronic cigarettes were modestly effective. These are some of the data. Okay, so these are from you can see here 7.3 nicotine e-cigarettes, 5.8. There's not much difference between them. There is effect. There's maybe help, but it's very modest. It's nothing compared to others. You want something really outstanding to take it seriously. So are they efficient in a smoking cessation? Likelihood to stop smoking? Again, it's low certainty evidence. So either the evidence is very low or very low certainty. Okay, either the evidence is poor, the data then design is wrong, or we are not sure. We can make conclusion from these data. You can see, it's almost like crossing the line of neutral. Are they efficient in a smoking cessation? Likelihood to stop smoking? More high quality research needed. All this data done, and at the end they say we need more data. So that means really it's not. So maybe these are the 4 important evidence here: 3 pragmatic, 1 clinical. So and again, when you come to significant better than control group, only the 1 pragmatic and 1 clinical say yes. And quit rate 6 months e-cigarette with nicotine, you can see it's range from 7% in pragmatic to 18%. You don't know. You got lost actually. And from real life data, and again you can see 32 lower odds of stopping smoking. So studies report a wide range of results, no definitive conclusion. Confounding factors, heterogeneity, e-cigarette devices and e-juice nicotine concentration, doses available in the market today, different lengths of time of cigars used among, we don't know, not mentioned. Smokers' intention to quit or reduce cigar smoking prior to and during their e-cigar use, you don't know what's their intention. Of course, difficult. So in UK, almost 900,000 people used e-cigars in England to quit smoking. Did it help? Was that the reason? So if you look here to 1996, so this actually the prevalence is coming down in England, United States, and Australia. But look at England, remain higher than others, although they were the first or the highest place e-cigars. So why? What's the problem? But it's coming down. So that's the conclusion. It says, it should be had really a more effect if that's the true. If the e-cigar had effect on stopping smoking, you should have seen much deeper, but not there. Here, tobacco price, that's the reason. Tobacco price index relative to the retail price index. You see that's in red, it's going up. That's why. I think that's the, money talks, money. So smoker will fully replace conventional cigarette with the e-cigarette. That's what we think. This will go away, this will come. But what happened? The majority will not. The majority do this. So supplement, have both, not one. 2 problems now. So this is really happening. So e-cigarettes consumption is increasing. We don't see that cigar consumption is reducing. That's how in the US, that's in the worldwide. So what happened? We see the pharmacotherapy, which is evidence-based, based on randomized clinical trial, shows evidence to improve stopping smoking. We see that going down. The uptake of that going down. Cessation services, behavior approach, all that. It's not, it's not people not attractive. What is attractive is e-cigars. Not only that, people continue smoking. So that's the problem. Dual users, cross-sectional population-based studies showed that strong association with respiratory symptoms. We've seen that, people, if you continue smoke and e-cigars, See how much harm you get to at least to the lung. Worse self-reported general health and worse breathing. Longitudinal studies, which are more important to follow the patients, higher risk of self-reported respiratory disease, higher prevalence of metabolic syndrome, toxic exposure is greatest. So e-cigar for smoke cessation going up, you see, up, pharmacotherapy down. It's another way to look at it. Okay, so is vaping hard to quit? What happens if somebody start to vape and continue? And even now we have two problems. We have a problem with the cigarettes. Now we have a problem with taking them off vaping, and that's why it's increasing. So a face-to-face survey, general population in Italy, 6% reported ever a cigar use. And conclusion, those restarting smoking after using e-cigars contemporary those who stopped smoking after using e-cigars. Are e-cigar a gateway for smoking stopping? I mean, I don't know. I mean, I think what we see actually, cigars use, is maybe coming down, but e-cigars is going up. Is another way of look at this, and this is the problem. The stars, they should be a role model. The problem, this wrong role model for our people nowadays. And of course, this is what they say. This is what happened among our kids. They smoke. Pregnant. That's people try to stop smoking during pregnancy by counseling is important, but these people will give them e-cigar. I don't think it's a good idea because the association of that with fetal abnormality is reported. So the best thing smokers can do to improve their health is to quit smoking. And that's what we all agree. That's we need to, as a physician, as a health provider, we need to say, no smoking, no e-cigars, both. Okay, now you cannot stop smoking. Okay, can I then maybe will replace you with the e-cigar? But I have to tell the person, all the benefits and the harms, and where the benefits comes. If it's only for short term, not especially if the person going to continue both. So, so we've seen there's low quit rates in pragmatic and randomized trials. We saw that it's very low. Real world use seems to undermine cessation. Yeah, we saw that as well. It seems to undermine the use of evidence-based smoking cessation. We see the medication, which is good evidence-based, is going down, not being properly uptake because they are attractive more to the e-cigars. Or vaping are used as a supplement. We saw that together, not as a replacement that we're aiming for. So really, it's a difficult balance. We try to tobacco reduction. That's what we try to do. Harm reduction, tobacco cessation by doing e-cigars. But really, it's a gateway to nicotine addiction. Tobacco normalization. People, become khalas. And then maybe they go back even to cigarettes. Dual consumption is happening. Long-term toxicity, we don't know. And so I think this was kind of a quick overview, and I'm sure there are lots of questions around this, and then maybe I've finished maybe well in advance time, but I think I leave my colleague and Dr. Juwairiya to introduce that. Thank you.
Okay. Thank you, Dr. Abdullah. It's a very interesting topic, and it's a very lots of conflicting evidence and lots of difficult things to cover. There are a couple of questions, but we'll leave them till the end. Now we have Dr. Sandy Gupta from UK. So he's going to talk to us practically on how to start smoking cessation therapy, especially in cardiovascular patients.
Thank you. And thank you very much indeed, Dr. Juwairiya, for the nice introduction and nice setting the background for e-cigarettes by Dr. Abdullah. I'd also like to thank the Emirates Cardiac Society and Pfizer for supporting this educational event. And I'm astonished that nearly 280 people are on this webinar. Amazing. My only worry about how successful the Cardiac Society is with these webinars, you'll never invite me to Dubai again, isn't it? I'll be stuck in wet, rainy London always. Anyway, so just at the end of the day, we are cardiologists and we're doing lots of different jobs. And whilst we need to focus on smoking and tobacco and harm and talk about strategies of cessation, I like to put it in perspective about all the other risk factors as well. Should I start with a conclusion? So the conclusion in terms of cardiology remains the #1 killer, whether you're in the Emirates, Middle East or UK, coronary disease. And what we like to summarize is lower is better. Because whatever our risk factors, our waist circumference, our cholesterol, our BMI, our heart rate, proteinuria, everything, lower is better. This is just an interesting slide of blood pressure, hypertension. What we now know that to be optimal is less than 120/80, that you'll save more nephrons and you'll have less cardiovascular events. So lower is better. This is the story of cholesterol. This is 30 years ago, I think, these collection of studies, 40 of them. Again, lower the LDL, better the outcome. And if you look at heart rate, and obviously in the coronary care unit, we have monitoring. And if we look at what we like in our cardiac patients, coronary patients, is lower the heart rate, the better. And if you look at different animals, humans and camels tend to live longer because their heart rate is lower. So in a world of 7 billion, every year around 60 million people die, total death rate, of which 17 million are from cardiovascular disease. But they are not in rich London, New York and Tokyo. 80% of the deaths are in developing and middle income countries. Now, if we forget about the deaths for 1 minute, every year around 20 million people survive an MI or stroke. The reason I show this is that I want to remind everyone there is not a single cardiologist in the planet who cures a patient from coronary disease. They all come back. And if you look at MI, stroke and peripheral vascular disease, their chance of further MI and stroke is 5 to 10 times greater. In the cath lab, let's say we have 8 angiograms, often 5 or 6 are previous stent or bypass patients. When we go to the emergency department or our clinics, they're full of old friends. The patients keep coming back. And so the message remains risk factor, aggressive reduction, and also secondary prevention. And a very famous paper that many of you are familiar with is Interheart. Is an MI in Abu Dhabi the same as in New Delhi, the same as in Sydney, and the same as in Manchester? Yes, 80% of the world's MIs are explained by 4 risk factors: diabetes, cholesterol, hypertension, and tobacco. And then if you look at the Interheart study, smoking accounted for nearly 40% of attributable risk for the first MI. Big risk factor. And, you know, in addition to doing webinars, we like doing voluntary talks, whether it's schools, colleges, media. And I was on the radio earlier this year before the pandemic started and talking about risk factors. And a patient came on the radio and said, Dr. Gupta, I'm fed up of listening to you because all you say is don't eat this, walk more, do this, take this. He said, when your time is up, your time is up. Leave us alone. And you know what I said? I said, Mr. Khan, in the year 2020, it's very difficult to die, very difficult to die. But what is easier, if you don't stop smoking, take your tablets, have your heart checks, you will need a leg amputated. You will need an oxygen cylinder for your heart failure. You will need your 3rd stent. So we need to remind our patients, as cardiologists, we're not just interested in long-term survival. We want people to live healthy morbidity reduction. So smoking increases the risk of death from coronary disease by 70%. And smokers are 5 times more likely to have a non-fatal MI than a non-smoker. If we go back over the years and decades and century, what we know that even as far back as 1848, they learnt for the first time how harmful tobacco is. And this was published in the Lancet in 1848, where they found how a tremor resulting from the habit of smoking was an additional evil. Even we go back 60 years ago, the Framingham Heart Study, that recognized smoking as a cardiovascular risk factor. So it's been a problem with us for some years. And as Dr. Abdullah has mentioned, the ingredients of e-cigarettes and also the ingredients of tobacco and different kinds of tobacco. So how many patients, how many of the public are aware that one cigarette contains 2,000 chemicals and 60 of them are direct carcinogenics? I want to change my conclusion. With traditional risk factors, lower is better, but with smoking, as Dr. Shahab said, it's 0 is better. And if we now just become a little bit more positive, how well we've done in cardiology in terms of ischemic heart disease. So if you look at all of our secondary preventative interventions after an MI, each thing we have here, the statins, the ACEs, the beta blockers, antiplatelet therapy, primary PCI, 20 to 30% reduction. But did you know that if you are a smoker, not only will you get the secondary preventative medication, but if you stop smoking, you know the benefit after your MI is 36% reduction. So stopping smoking after your acute coronary syndrome is as good as taking your aspirin or your statin. And this is the data of that evidence of a meta-analysis looking at event reduction by stopping smoking. When we are in the cath lab, and we're often seeing patients represent with new lesions or progression of the existing lesions. And if you look at those who are current smokers who come back to the cath lab, it's a strong risk factor for atherosclerotic disease progression. And if you speak to our cardiac surgeons, they will say when they see follow-up, patients who continue to smoke after a new set of arteries, a bypass, have more than twofold risk of coming back for another bypass. And as we know, stent thrombosis or events after PCI higher in diabetics and smokers. There is this thing that patients may say, oh, doctor, I only smoke 1 or 2 a day. It can't be doing any harm. But if you look at this evidence here from Teo, published in The Lancet, that even 1 or 2 cigarettes a day, there is greater risk of cardiovascular events compared with no cigarettes. And this again emphasizes what Dr. Shahab says. We're not really interested in smoking reduction or change in the tobacco strategy. It's 0 total cessation. What about the issue of second, third-hand smoke? And this is very important because you know what happened is that the governments around the world decided to ban tobacco in public places, in airport lounges, in hotels, restaurants, train stations. And the reason is because the non-smokers, so you and me, we were fed up of dying related to smoking. Secondhand smoke, a very powerful thing that nations can do, in addition to what Dr. Shahab mentioned about increase in taxation. So, question, how many cigarettes are needed to cause an MI? Well, if you are vulnerable, if you have the predisposition, maybe just a handful enough could turn the cells into an aggressive form of endothelial damage, prothrombosis, and an infarct. It's a bit like caffeine. Caffeine affects people in different ways. One person can have 7 cappuccinos and a day and not be affected. Another person has 1 and they have a tremor and they panic. So I think there's variation and risk. How quickly does a cigarette cause harm? So if you take a puff of a cigarette, how quickly does it cause harm? Well, there is some evidence that the smoking chemicals begin to affect endothelial cell damage, free radical damage, prothrombosis within minutes in certain groups of patients. Patients may say, okay, doctor, nurse, pharmacist, you keep saying smoking is bad for you. Why or how? And this is a slide you show your patient. So it's not just the nicotine, which is not just addictive, it is sympathetic stimulation with heart rate issues, tachycardia, hypertension, but also the carbon monoxide and all the chemical agents within the cigarettes, which we've discussed. And then what they're causing is inflammation, endothelial cell damage, insulin resistance, and a prothrombotic state. What kinds of tobacco? This is the point that's already been made. They are all harmful. And nicotine as well. It's not just addictive, it has a number of vascular and non-vascular harmful effects. E-cigarettes will come to the debate later. This is a slide you will always remember. You will never forget this slide. For every one cigarette you smoke, you will lose 11 minutes of your life. And when I show this slide in a talk, I see people adding up how long have they got left. If you have 1,000 20-year-old smokers, how many will be murdered? Well, it's just an estimation, but maybe one. If you have 1,000 20-year-old smokers, how many will die from a road traffic accident? Well, it can vary, but perhaps 6. And finally, if you have 1,000 20-year-old smokers, how many will die in middle age from smoking? 250. Just see the scale of harm that cigarettes cause. But let's again be positive, because I think one of the issues as clinicians, maybe we scold our patients, we tell them off. Why are you overweight? Why are you taking alcohol? Why don't you do some more walking? But if you say the benefits of doing less of those things, that perhaps has a greater initiation of intervention by the patients. So if you look and tell patients that, you know, after a few days of stopping smoking, you'll be able to breathe properly. You'll be able to smell properly. Your skin will feel better. And also the parameters in the circulation will improve. And then as the longer you stop, look at the outcomes. You will reduce cardiovascular events by 50% just by 1 year of ex-smoking. And once you've been an ex-smoker for 15 years, you're like a non-smoker for cardiovascular risk. So every day that you're not a non-smoker is worth it. You know, happily, clinicians, we prescribe blood pressure tablets, but when you have a smoker in your clinic taking blood pressure tablets, remind them that the blood pressure tablets may not be as effective. Interaction. We like prescribing statins. Remind your patients, you're taking statins, very good, well done, you need them, but if you carry on smoking, the statins are not as effective. And it's a bit like aspirin. You can tell your patient, you know that aspirin a day is thinning your blood. You know that cigarette a day is thickening the blood. Your aspirin's not working. So I think if we go in that kind of language, people may understand why it's important that we are preaching this mantra of stopping smoking. But let's move on to interventions to help patients stopping smoking. And over the decades, there's been good data for a number of pharmacotherapies, in particular bupropion, NRT, and varenicline. And also, I think Dr. Shahab has mentioned that you don't do this alone. You have counseling as well, whether it's through webinars and telephone, or whether it's the ability to do face-to-face. That needs to continue during this period of, if you want patients to long-term stop smoking. Because interestingly, this is data, this is not just anecdotal. Most smokers wish to quit, if you were to look at studies and surveys. But how many manage to quit without help? Very few. So whilst the motivation may be there, you need to encourage them to join a smoking cessation program, whether it's done by clinicians, pharmacists, nurse specialists, or people trained in smoking cessation. And this is an interesting slide. This is the brain of a non-smoker. This is the brain of a smoker. I have no idea what this slide means. All I know is that the brains are different. I do know. What you can see here is nicotine receptors hyperexcited in smokers. And when they give up smoking, these become very irritable. And so it's very difficult for people to stop smoking. So you almost have to look at the pathophysiology. And this is why there's been clever molecules developed, namely varenicline, which act on these receptors. They compete with nicotine, but they also allow a little puff of dopamine. And by completing a 12-week course of such therapy with counseling support, patients are most likely to long-term quit. So back to cardiology, because this is the focus in our webinar. Our patients with an acute coronary syndrome or coronary disease stable come in on nothing, but they go home with a whole sack of drugs, your antiplatelets, your beta blockers, your ACEs, statins, diuretic, GTN, other kinds of anti-anginals. What about smoking cessation pharmacotherapies? Safe to use? Well, this is a study published by Nancy Rigotti 10 years ago, looking at varenicline in stable cardiac patients. This was the quit rate with placebo. This was the quit rate with varenicline. And you can see at 52 weeks, much greater chance, almost double the chance of long-term stopping with varenicline in stable heart patients. What about harm? Look at the event rate in terms of adverse, no different between varenicline and placebo. Now, what about the EVITA study? This was in acute coronary syndromes. So the coronary care unit, smokers, given this traditional ACS protocol, but also randomized to either placebo or varenicline, ACS patients. And what they found is that if you look in blue here at 4 weeks, 12 weeks, and 24 weeks, greater chance of success than total abstinence in those who receive varenicline. And in terms of harm, similar to the Rigotti study, safe. And the one final study I need to mention, I'm sorry about the blurred slide, but the EAGLE study, published a few years ago in the Lancet, a huge study, very important message, 2 messages. One, well, before I come to the messages, very big study, 5 continents, 16 countries, over 8,000 patients. Half of the patients, let's say 4,000, had a background of neuropsychiatric diagnoses. The other half, the other 4,000, non-neuropsychiatric. Now, all of these patient groups, 4 in the neuropsychiatric, 4 in the non-neuropsychiatric, got one of 4 regimens: placebo, bupropion, NRT, or varenicline. All run in parallel in terms of event reduction, in terms of neuropsychiatric issues, and also what differences in stopping smoking. So huge study. And this was the bottom line. If you look, it's a little bit complex, but the message is this, that if you had no psychiatric history and you got one of 4 of these therapies, the greatest chance of stopping smoking was with the varenicline group. And if you look up to 24 weeks, similar. If you then look at the psychiatric cohort, greatest chance of success stopping smoking at 12 weeks, varenicline group. And even up to 24 weeks, and we know that the psychiatric patients are much more resistant to stopping smoking. But again, the greatest chance of stopping is with varenicline. Now, the other issue of harm, adverse effects, and you can see here no difference between varenicline, bupropion, NRT, or placebo. And in fact, varenicline had less side effects than placebo itself. So 2 very important messages. Efficacy, greatest with varenicline, and in terms of adverse, they are all safe to be used. And within this study, the EAGLE study, there was a subgroup of patients published as a paper in the CAT study looking at cardiovascular events, and basically across the board, very low and no excess in any of the pharmacotherapies. Very reassuring 2 papers. So as Dr. Shahab mentioned, money talks, and we have to realize that healthcare comes with a price. If you look at cost effectiveness, bypass surgery, various rehabilitation programs, interventions, actually there is nothing as cheap and cheerful as stopping smoking. And this is what I like to say, short-term pain, maybe it costs some money for pharmacotherapy, but it's long-term gain. And this is what we have to convince our hospital accountants and people who write the checks for healthcare, that a program of smoking cessation with the right pharmacotherapies is worth it, because people will have less events, people will need less admission to hospital, people will have less days off work. It's worth it. And you know, in my hospital, and I suspect it's the same in UAE, one night in a coronary care unit, one night is about £750, which is about £500 more than the suite at the Grand Hyatt. How expensive being in hospital is. And if we look at NICE data, for every £1, what's that, 5 dirhams invested in smoking cessation, the return is £2.37. And there's no bank account in the world, no bond in the world that gives you such better return than investment in smoking cessation. So cardiologists, clinicians, we need to do more, better, we need to improve. But there's no doubt some groups are doing superb. We need to ask, advise, assess, assist, and arrange. And I think cardiologists across the globe had previously just fired and forget. Do you smoke? You need to stop. And then we walk away. I think we need to take a more proactive role, like we do with our coronary interventions, like we do in how we treat diabetes and hypertension. But we don't have to do it ourselves. We're very busy. As long as we have a team, whether it's next door in the clinic or a helpline that the patients can get, or tell them to walk over to that corridor and that room over there, you'll meet Lynn. Who's Lynn? She's our smoking cessation nurse. She'll go through all the options. And I think this is going to be a key way forward, working as a team. But there is no doubt there are very good clinicians who are trained in smoking cessation, and they continue to be very influential. And this is, again, the pride of cardiology. We would like to think when we have patients in the cath lab, in the clinic, in the coronary care, they tend to listen to us. So we do have some kind of impact for our patients. And I remember a few years ago in our local hospital in East London, as the patients checked in for their outpatients, that's about 100 patients a day, the receptionist asked them to fill in this one form. Easy. Name, address, telephone number, email, smoke, don't smoke. If you smoke, are you happy to be contacted with smoking cessation services? And we found that cardiology was a big provider of referral. So a busy slide, but just highlighting, we need to ask, we need to advise about the importance of quitting, we need to refer or assess ourselves, we need to assist, and we also need to arrange follow-up, because the data shows if we follow up patients 6 months, 12 months, a year plus, and check on interventions, check on lifestyle changes, they're more likely to be compliant, they're more likely to have good results as well. And there is this concept called TM, teachable moment. And the teachable moments for healthcare are when the patients are in hospital. When they have a clinic visit in blue, in test result in blue, and in pregnancy in blue, and in hospital as a patient, inpatient in blue here, highest chance of stopping smoking because we've got them under our roof. And they are frightened because they've survived a coronary event, but they are receptive to advice. So what's the next trend? The next trend is to start therapies in hospital, but make sure primary care, community care follow up. So there's a seamless service for that journey for smoking cessation. And this was shown in a number of programs, and this shows that if you follow up patients, looking at readmission rate and even survival, the data is so strong when you follow up patients who've gone through a successful cessation program. I've probably said a little bit too much. I do apologize, Dr. Jawari, but I think this is an interesting proverb from Chinese text. Superior doctors prevent disease. Mediocre doctors treat disease before it's evident, and inferior doctors, usually cardiologists, we treat the full-blown disease. Finally, what's the biggest room in the world? What's the biggest room in the world for anything and everyone? The room for improvement. Thank you very much.
Thank you, Dr. Gupta. That was amazing. It's a very comprehensive review. So let's go over some of the audience questions. So the first question came in for Dr. Abdullah. It's regarding using e-cigarettes for quitting smoking. If a patient uses that for quitting smoking, how long will it take for him to quit?
That's I don't know. I mean, to be honest with you, I mean, the aim is to be in short term, and the patient, the person not to continue with the e-cigarettes for long. That's the whole idea. But the problem is, it's not like a pharmacotherapy, which we have, certain time, certain weeks, and we expect a person. But it's a change of habit. I mean, it's the same kind of habit they used to smoke, and the similar kind of behavior, but is replacing. Supposed to be the harm, of course, up to as the people claim. So if they can do it in the quicker, the better. So I mean, to be honest with you, I've read a lot around it, but I don't know the exact time. I don't know, Dr. Gupta, you have any idea about this?
Yeah, I think it will vary. I think you're right. And we're not that experienced with it. We know it's a tool. And I think my view about this vaping and e-cigarettes is that health professionals are divided into two. One group say this is safer than cigarettes and should be the stepping stone to quitting. But the other group say, fine, but where's the long-term data? And if you Google every day, as you showed many of the papers, the harm coming out with respiratory, toxin, or cardiovascular with e-cigarettes. And I think the other thing you highlight, Abdullah, is that we've created a new disease. So many of these teenagers were never smokers before.
Exactly.
So vaping, and you know what? Partly blamed because of the companies. And I think there was one slide or somewhere I read 250 different flavors, from cinnamon to green tea to blackcurrant. So people don't realize the potential. In my high road, they've just opened the 5th vaping shop. It's more easier having an e-cigarette than having a haircut in Loughton here in East London.
You say that.
And it's often the hairdressers are selling the vaping.
Yeah.
So another question is about, is there any evidence-based approach to treat vaping addiction? I guess there's no evidence for vaping itself. So, I mean, if you want to take that.
Yeah, I mean, that's the worries, that's what's happening nowadays, Dr. Juwairiya. And I showed you the data, it shows the people, using an uptake of this as a replacement of the evidence-based therapy, which Dr. Gupta showed us, where the evidence is there of the benefit, and through the randomized clinical proper design. But the problem is, because this is so easy, it's resemble what they've been doing in the past. And as Dr. Gupta said, there are some people likes to even try this new tool.
I heard in India that they banned vaping, but they've allowed cigarettes not to be banned. So there is lots of confusion even within governments. Yeah.
Okay, so the next question is actually for you, Dr. Gupta, about so 2 questions addressing that is the side effects of vernicillin. So they're talking about incidence of depression and suicidal tendency, especially for post-MI patients who are already depressed. And the other question was again regarding that and asking how is it that it's the same with placebo? They feel that patients are more likely to be anxious and depressed with vernicillin. So what's your take on that?
So I think, Dr. Jabari, that it's a very valid question, but I think it's been dealt with. And the reason why I think it's been dealt with is those 3 studies. The Rigotti study in stable coronary patients, the Evita study with acute coronary syndrome patients, and the Eagle study. So if we go by evidence-based, that the placebo and the versus varenicline for adverse psychiatric or neuropsychiatric issues is the same. That's what the data shows. I accept people have got anecdotal experience. So people who have dealt with resistant psychiatric patients who are a little bit unstable, there may be some nervousness. But I want to turn it around and say the risks of these things are low in relation to the risk of carrying on smoking. So I think we need to balance that. And if that's the greatest chance of success, and as long as the patients are carefully followed up and counseled, and we spot the ones that are, becoming unstable with psychiatrists and pull them out. But I don't think we should deny a whole population of resistant smokers, the psychiatric group, this opportunity. The benefits greatly outweigh, and the data, especially with Eagles, show 5-6% adverse events similar to placebo.
So another question, but I mean, you answered it in your talk, but maybe just re-emphasize it because it came as a question. So they're talking about post-MI. Can you start varenicline or nicotine replacement immediately post-MI? You had a slide about that, so maybe just re-emphasize it for the group.
Yeah, I think that, again, it's new news in a way, because for years we're trying to stratify our therapies for post-MI. We've got lots of antiplatelet combinations, we've got high-dose statins, we've got ACEs, beta blockers. They remain the priority, but all we're saying now, we need to, in cardiology, upgrade the importance of stopping smoking on day one. And day one can be prior to discharge. The people have stabilized, they've had their intervention, they're okay with the other therapies. We need to start working on them. And the data is showing we can safely start the therapies, including varenicline, in hospital. And as long as there's a plan when they leave hospital in cardiac rehab, primary care to follow up.
So another question, maybe any of the speakers can take it. So asking about passive smoking, how dangerous it is compared to active smoking.
Depends where the passive, what do you mean by passive? Is it in a family where, I've been to different countries, there are places where everyone in the family smoke, and that's, if you are there, you're really passive, and it's really active, I know, I'm sure you know the country I'm talking about. There are countries where, the family, they stay away from it. So it depends, how close you are. Proximity is important. Shisha, for example, we have places where we go to a coffee shop. Alhamdulillah, good thing about the COVID, they stopped all this. We used to sit and we thought, oh, we are not smoking, but you're exposed to them, and you are on long term, of course. And sometimes this exposure is so intense that if you are not kind of a smoker, and to what one episode like that is, your lung, that day you will not be able to sleep. I mean, it happened to me in the past.
Yeah, absolutely true. It happened to me. I entered the room wearing my mask during the COVID area, and I can tell you I could not breathe. And then as I left, until the next day, my mask smelled like smoke because that room was completely compacted with smoke. Yeah. So yeah, you're absolutely right.
I think, Dr. Javari, there's not just the sad evidence of morbidity and mortality in passive smoking, but it's also just not fair, is it? That you have a car of young children, and they say that if you smoke within the car, the concentration of tobacco and chemicals is 5 to 10 times greater. And the kids they didn't consent to that. They don't have a choice. And there is this thing called third-hand smoke, that even when the person has stopped smoking, as you say, your mask can close, you can smell tobacco the next day. So I think the evidence is clear. It's just not fair on society, and it's proactive in so many countries to ban public smoking. Yeah.
So we have a question from someone who works in a smoking cessation clinic. So she's been managing patients for a while, counseling them and using treatments. And then she has many cases of relapses. And she says, and relapses options are really limited. So what do you think in that case? What do you do? How do you approach relapses?
Yeah, that's interesting. There's that famous American author, Mark Twain. He wrote, stopping smoking is the easiest thing to do. I've done it thousands of times. So what the data shows is that it takes 6 to 7 goes before that person eventually quits. But you're right, there's always some people who've quit and they have a row with a neighbor, or they lose their car keys and they start smoking again. So I think that life events is an issue. So in terms of the practical ways forward, there is data of, let's say with Brenacline, to have another course. So it's not, there is evidence that I think it's from Oslo, there's data that showed patients who relapsed who got another course of Brenacline, it's fine to give. But I think that smoking cessation experts, the people in the clinics, they anticipate relapse. And so they tell patients, if you do relapse, this is what you need to do. Quickly get back to the strategy. And it's all about setting a quit date, a realistic one. So not stopping straight away. I think there's just various strategies that people use, but never to sort of give in if they do relapse. Yeah. I'm sorry, it's a little bit vague, that answer.
So another question asking if there is smoking cessation clinics in Dubai. Yes, there is. So they're usually located in primary healthcare centers. And they're distributed all over Dubai, so you can get in touch with them. Another question asking, can you combine nicotine patch with Chimpax tablets for cessation?
I think my understanding is no, because the whole point of Varenicline is to be a nicotine receptor inhibitor. So it's probably not a logical thing to do. But I mean, nicotine receptor patch, NRT in different forms, has been proven. We mustn't dismiss it, and it suits some patients. But I think, that slide I showed with the brains, the heavily addicted patients, we can understand why they are tough in terms of long-term quitting. And that's why Varenicline, because of its molecule, alpha or beta-2 inhibitor, has this way of realigning the nicotine receptors. I think also if we tell patients that, look, it's not their fault, they're addicted. They've been doing this for a number of years, but it's to tell them we have a strategy to help quit.
So, so someone asked, why didn't we talk about shisha, as it is very common in the Middle East? Dr. Abdullah.
Why we don't talk about shisha? Yeah. Well, I mean, shishas nowadays, alhamdulillah, has been banned because of the COVID. I think the great thing about COVID is really, we've been having a great, weather and oxygenation, and so I don't know. I mean, shisha is very bad. I mean, people I see in my clinic nowadays, they have shisha at home. Of course, they manage to, find alternative at home. And this is the amount of, I mean, the doses they get from the shisha is like, one pocket of cigarettes, in one go, which is really very harmful. But and actually, I had few of them coming to me with MI, and I have few cases. I didn't report them, but this is from my experience. I don't know, Allah. It's, I mean, how to again, this has come with a social, Dr. Juwairi, where the people like to go in coffee shop, and especially in with the nice weather nowadays, they like to, but alhamdulillah, still the COVID there, and it's not I don't know what Dr. Gupta says about the shisha. I don't know, they have shisha.
Yeah, we do have in London a number of places where shisha bars are there, and also you can have different flavors again, isn't it? So it's the same disguise that people, especially the youth, don't realize that underneath it's still tobacco. I think it's going to be the same thing of treating it like cigarettes. Governmental impact health authority impact, strategies and education. And I think like we had that question about how to get people to stop e-cigarettes. If it's an early thing they're trying, they're more likely to stop rather than if they carry on. So we've got to grab them early, quickly alert them to the benefits of stopping. But it's a generational issue, isn't it? It's a cultural issue, as you described in the Middle East. Yeah.
So another question about vernacular, how long should it be used? Is 3 months enough, or should you use it longer than that?
Good question. The evidence in terms of the licensing is 12 weeks, but in some resistant patients, and again, in those who have relapsed, another 12-week course is possible as well. So we wouldn't recommend beyond that. But traditionally, what patients say, it's interesting that if you were to ask them, brilliant, you've managed to stop smoking. And they say, yeah, it was that course of varenicline. And you know what they say halfway through that course? I don't feel like smoking anymore. And that's a really nice thing to hear, because they know themselves that it's becoming a benefit. It's a bit like weight loss, isn't it? When your belt is one notch looser, it's working. And I think that's what patients say. 12 weeks and some 24 weeks.
So another question about e-cigarettes, asking, is it true that the manufacturers of e-cigarettes are the same manufacturers of regular cigarettes? It's just a hoax.
Well, I don't know. I mean,
that's political, too political.
As I said, I have no conflict of interest in any of these two. Yeah. I don't know. My questions to since we are all physicians here, and 5 A's is beautiful, and really we have to apply it everywhere, not just to cigarette, everything. When you advise, assess, and assist them as well to really advise them and follow up. And anything I think is important, to spend some time with our patients. The problem we are not patient enough to spend time with our patient. And the other thing I noticed is, when you look at the data, most of people really stop smoking. It's without, this kind of, pharmacotherapy. So that means, we need to work on that. We need to build and willpower on these people. And then the medication, of course, for those who are resistant, because most of them really stop smoking. I've seen them, at least in my clinic. And when it comes to using this evidence-based therapy, which Dr. Gupta showed, I think should be done in an appropriate way, done through the people who are expert, not just label themselves as smoking cessation or something. No, you have to be patient as well. As you are patient with any pharmacotherapy, you need to be patient with it. You need to explain to it. I mean, people say, Doctor, I know you're telling me there's no placebo, no similar side effects to placebo. Yes, because that's randomized clinical trial showed that. But in real life, you tell the patient everything. You tell them about nocebo or the placebo effect. They will get, and it depends how you tell the patients. I think it's important to invest our time, when we use this established medication. Otherwise, it has, no meaning. I don't know what your thought on that.
Yeah, I totally agree. And I think we're so busy, Abdullah, but we're busy saving lives, whether it's putting a defib in or stent in. We're not on a sunbed. So, and we can't be experts in everything. And this is why in the UK, what we, in my institute, we have a team. And I was speaking to Dr. Jawari before, that we as cardiologists are powerful enough to direct patients, but we need to say, look, I'm not going to forget you. I need you now to meet Lynn or whoever, or our clinical pharmacist who's trained in smoking cessation. As you say, no one should be dabbling. Everyone, and also patients, should be offered all the options and know the evidence and know it's going to be a tough journey, but it's going to be worth it. By the data of, after a few days, they can smell, they can breathe, lung function improves. After a year, they reduce their death rate from MI by 50%. I think those things, but I think working as a team and training up whether junior paramedical staff or nurses in, we have arrhythmia nurses, we have heart failure nurses, we have smoking cessation nurses. I think thinking about that kind of team
Dr. Jawari, what about you? What's your thought on this?
Yeah, I agree with both of you actually. So it has to start with the cardiologist, because you're the one who's first in contact with the patient. But then, yes, you need to send them to somewhere where this is what they do every day, every single day, because they're gonna need to deal with all the excuses, deal with all the challenges, the depression, and we might not have, as cardiologists, we might not have patience for that. So someone here is asking about the cost, the price for nicotine substitute in comparison to continuing to smoke. I mean, the question answers itself, because if you continue to smoke, you're going to smoke for your life and you're going to spend the money for your life, whereas this is a 3-month period that you're going to, whatever. It ends.
What they say, short-term pain for long-term gain, yeah?
Exactly, yeah. So, yeah.
And also the cost of, let's say, a 3-month course of medication is probably cheaper than the cost of all the cigarettes.
Yeah, probably. So
okay.
So another question, is the endocannabinoid receptor zone in the brain closer to mood changes such as causing suicidal attempts? Well,
we used to be cardiologists, now we're neuropsychiatrics. Yeah.
That's by surprise too.
I think the lay message is that we understand how addiction occurs. In the hard 20 cigarettes a day from age 15 to now 70, we can understand the changes of the receptors. And the way to readjust that is look at the special pharmacotherapy. But I think Dr. Abdullah also said that you don't need tablets for everyone. You know, just surviving a stroke or having your leg amputated or having your bypass is enough for people to stop, for some. But it should be available for those who cannot do it themselves. And the evidence shows only 5-6% manage themselves.
So someone asked another question: should you use like a short-acting short course of nicotine replacement therapy while you're using vernicillin until it starts to get an effect, like a short combination at the beginning and then go through just?
I suspect it, you know, again, not one size fits everyone. So yes, you know, people who need immediate relief and where you have a molecule that will take a few weeks, it seems logical for a handful. But I think it's just to make sure we understand how varenicline is working. It's basically inhibiting the nicotine, so you don't want to keep re-challenging. But I think these short patches and the gums and whatever, it should be fine in a group of patients. There shouldn't be any risk related to that. But the aim is to get them off that. And hopefully, as a few weeks into therapy, they'll begin to realize they don't need any nicotine replacement.
So someone else says you need to treat both the habit and the addiction. So you need to treat, how to treat the habit and the addiction. And I think that also drives into another question about, e-cigarettes that are nicotine free. So and this comes also from patients as well. They say, well, it's nicotine free, so can I use it? What do you think, Dr. Abdullah?
I mean, nicotine free and there's no smoke. There's as well something like that. But I mean, where's the joy? There's no joy. I don't know for them. I don't know. I mean, I don't think it's well taken, uptaken by the, people like to see the smoke and to have the nicotine. And that's why the e-cigarette has been, been so attractive to them. But without nicotine, without smoke.
Well, the nicotine-free ones comes also in flavors like the other ones. But I don't know, like the way I answer the patients, I tell them, I don't know what's in there. Because that's the problem with vaping, right? You don't know what's in there. It's not nicotine, there's something in there, right?
There's something in there,
yeah. So how can you give a judgment on something that you don't know what it is? So yeah, No problem.
Good point.
Yeah. So another question. So one smoker is telling me that he used to smoke 20 cigarettes a day for 15 years. Now he smokes only 1 cigarette a day. What will be the effect of such habit on him?
So I showed that one slide where of MI risk, and even 1 cigarette a day, your risk of a heart attack is greater than no cigarette a day. But yes, the MI risk is less than if you're 20 a day, there's no doubt. But my question is, if you just need 1 cigarette a day, it means you're not addicted. You don't need it. So why not try and get rid of that 1 a day? I know for many people it's simplistic for me to say because that's their only pleasure of the day. But it's just to be aware that even that 1 a day doesn't wipe out the harm of tobacco.
So I'm not sure if this is a comment or a question, but they're saying e-cigarettes are as harmful as smoking regular cigarettes. I think Dr. Shihab, you showed that very clearly.
Yeah. I mean, as I said to you, there are different opinions. 95, there are people think 95 less harmful than the cigarette. There are people say the opposite, but the majority, of course, they think, still this is less harmful, but it's not harmless. Some harm.
So maybe this is like a behavioral question: how to start with a difficult smoking relative or patient, like someone who's adamant to smoke and not willing to quit. How do you start the conversation with this patient?
That's a great question, isn't it? It's a great, and in cardiology we handle so many different kinds of scenarios, from breaking bad news to redo valve operate. We're in that game all the time. I think it's to give them the hard data, saying that, look, how much are you spending on cigarettes? Do you know for every cigarette you smoke, you lose 11 minutes of your life? We're not just here to make you live longer, but there's risk of being unhealthy. Your lungs are going to pack up. Your risk of 16 different cancers is much greater. And then to quickly swing towards the positives, meaning look how much you will save, look and see what your risk will come down to. And after you've gone through that painful period of 3 to 4 months, you will reap the benefits. And even if it means saying to them, let's give this a try, but don't force patients. I think this is the key thing. Give them the options and say, this is my card, this is my number, or my clinic, the number for smoking cessation. When you're ready, come to us. But we may contact you in a few weeks to see how you are. So I think we need to just tailor it according to, but I think over pressure doesn't necessarily work.
You see, there is a general key for everyone. For every person, you need to work on that. There are some people, visuals, some people listeners, some people are, need to work on their emotion. There are many ways, but we are physicians, as Dr. Gupta said. We are actually expert in this, how to do that. But it just needs tailor it according to who's in front of you.
And one other thing to add, Dr. Jawari, is that the messages we're trying to give as clinicians is, please don't wait for an event to change your life. How often we see people who've survived an MI or stroke, on that day, they walk more, they eat properly, they stop smoking. Why do you have to wait for that event? But I know it's human nature. But I think it would be nice to get people to tailor their lifestyles before. And often we say to patients, look, this is a deal. We'll sort out your blood pressure, but you need to cut back on less than 6 grams of salt a day. Yeah, we'll sort out your diabetes, but you need to cut back on the carbs, whatever. I think it's a deal, and we should be entitled to tell patients they have a responsibility. And if they're elderly patients, we work on their relatives or who they live with or their carers, whatever. I think it's a team approach. And then we had that question earlier about a family of smokers, whatever. I think we should But I think there is an issue of time, isn't it? How long do you get in a consultation or in a ward round? We have to triage what are the hot things, but we mustn't lose sight about how important tobacco is. And I think that, you know, you've got 320 people on this webinar. I'm astonished on a Sunday evening. It just tells us we're really keen to do this.
So another question is about sex differences in regard to quitting smoking. Which sex is better quitters, let's say, men or women? Any data on that? I don't think there's any data on the topic, but maybe that's another paper to be written.
Yeah, I think that globally around the world, probably the number of female smokers are less than in any nation, isn't it, compared to males? But I suspect the quit rate's the same, isn't it? I don't think there should be any difference.
So lots of comments from people.
Will you ask them to write good feedback, yeah?
Yeah, please. They're still listening, so.
Oh, in Jordan and Lebanon, more smokers are female. Oh.
They're saying in Jordan and Lebanon more and more.
Yeah.
Well, I'm not sure. I think, well, everybody, the whole country smokes.
Depends. Yeah. That's what I'm saying. These are the countries which has.
I think it's quite sad, isn't it, that here we are as clinicians and cardiologists talking about it, but we still have to work with governments and policymakers. You know, those things, taxation, public strategies are very important that clinicians have influence there.
Unfortunately, Dr. Gupta, I know this is sessions given by clinicians to our audience. They are different. Some of them are patient as well. The problem is, you know, the lead by example, lead by role model, and unfortunately, some physicians, cardiologists, smokers, cardiac surgeons, smokers. I don't know how effective their message to the patient, but this is need to be. I don't know. I mean,
yeah, that's a good point, especially in places like China and Japan. A lot of clinicians are smokers.
Yeah, that's true.
But we're humans, yeah.
And even for vaping, there was a comment about that, I think. But some young people right now are using it to lose weight. So you find these young athletic people who go on a diet and they're vaping during that just to lose weight. So it's becoming really a bigger problem right now.
It's a shame, isn't it, that the companies have allowed this to happen, isn't it? I know we don't really want to go into that debate, but how there has been no regulation almost, isn't it? Everyone is just setting up and it's just snowballing out of control almost. New disease.
Okay, so do you have any final comments? I think we went through most of the questions from the audience. They were great, actually, with engaging with us. Any final comments from you, Dr. Abdullah?
I want to say just, you know, our approach should be to our patient to raise the standard. You know, we're not just speaking about stop smoking. So we want to improve the health. So improving the health, one of the important pillars is to stop smoking, because we've seen how many people die of this. And it's easy. You can do it yourself in 2/3 of the time. And 1/3 we need some helps available in terms of behavior, in terms of, you know, medication, evidence-based, and e-cigarettes there to help you to quit, not to be a supplement, or not to be an associate with it. That's what I'm saying.
That's true. Dr. Gupta, any final message to the audience?
So, thank you, Dr. Javeri, for excellent chairing of this as well. I think I'm just very grateful to have been invited to give some personal views as well as the data, hopefully. And hopefully, as cardiologists, we will upgrade smoking cessation to business class. Yeah, upgrade it to all the other interventions we're involved with: lipid lowering, hypertension, diabetes, coronary stenting, and we as cardiologists take a role as well but work in a team, not necessarily individually. What we have to do, what do we say? We have to share the blame, and success has many fathers. Failure is an orphan.
Well said.
Thank you very much.
So thank you. We had like an amazing talk. I think this is the most engaging smoking cessation talk I've attended, and it's we had a great audience. I'd like to thank all the audience and the speakers, and I'd like to thank Pfizer for sponsoring this and Emirates Cardiac Society for organizing this. So thank you all, and hopefully in the near future, we can meet in person when COVID is done.
Dr. Abdullah, Dr. Jawari, when this whole COVID thing is over and we can fly again, will you send me an invite for UAE next year?
It's open, actually. You can come.
I'm not allowed out. The problem is I'm not allowed out.
So you are welcome anytime. We are open.
Welcome.
Thank you.
Lovely. See you soon.
Thank you, Dr. Gupta.
Thank you.
Thank you.
Bye-bye.